Dr. Waterchill is an assistant professor of medicine and director of the Adult Non-Alcoholic Fatty Liver Disease Program at Columbia University, New York Presbyterian, in the Center for Liver Disease and Transplantation. Dr. Waterchill leads a multidisciplinary team to confront the escalating public health crisis that represents NASH, covering everything from patient treatment and clinical trials to translational research, including genomics. Her clinical and translational research focuses on the discovery of targets and pathways associated with non-alcoholic steatohepatitis, also known as NASH, the development of liver cancer and non-alcoholic fatty liver disease, the integration of genomic sequencing and research in clinical liver diseases, and the clinical care and outcomes for NAFLD. She is a member of the Liver Forum and the NIMBLE Consortium, among other multi-stakeholder groups that have been designed to address unmet needs within the field. She is dedicated to community engagement and education inside and outside the healthcare system, and again, someone who I'm glad to have as a colleague. Dr. Waterchill, please come.
Thank you for that lovely invitation, Dr. Hollingsworth. Thank you to the organizers as well. We're gonna go ahead and get started, and these are my disclosures. So in order to understand this liver disease, non-alcoholic steatohepatitis, we'll get to the definitions in just a moment, but I'd like to zoom out a little bit and put it in the context of how we think about liver disease at large in terms of context and in terms of the lifespan. So if you just look at the far left portion of the panel there, we think that the majority of individuals are born with a normal liver, spongy, kind of like a soft sponge at birth. And through different chronic injurious insults to the liver, sometimes viruses, sometimes alcohol, or in this case, fat, the liver can sustain damage. And that damage generally takes decades. So the point of today's talk is to empower with education and talk about how this liver disease is certainly an epidemic, but it's also very modifiable and in some cases reversible. So it's just during this time course, the 5 to 50 year span of the accumulation of damage, that there are multiple opportunities to intervene. So it's overall quite hopeful when it comes to chronic liver disease. So with non-alcoholic fatty liver disease, and specifically non-alcoholic steatohepatitis, steato meaning fat, the Greek for fat, and hepatitis just meaning anything that causes inflammation in the liver, you see a serial progression in those who develop inflammation and scar tissue, which you'll see is described on the slide as matrix deposition. When the liver develops scar, we call it fibrosis. That fibrosis in NASH usually progresses a stage every 5 to 7 years. This is what we've known for the past 2 to 3 decades. There are certainly outliers, people that move through the disease process faster than others, and those who actually halt and reverse their disease process. We think of stage 4 liver disease, so end-stage scarring of the liver, when it's much more like a brick than like a sponge, as cirrhosis. And outcomes that are related to chronic liver disease, like liver failure, cancer, something that we call portal hypertension, which is a strong predictor of who lives and who dies with liver disease, as consequences of cirrhosis. So those of us that do transplant or general hepatology and transplant focus our efforts on those folks that are on the far right of the slide. So those that are more advanced with their liver disease and have consequences that sort of need rescue and replacement. That doesn't mean that we're not involved along the way. And as I reiterate some of the differences between non-alcoholic fatty liver disease without inflammation, without scar, to the spectrum that includes the more angry, as we describe it to children, inflamed and scar version of fatty liver disease, that's where multiple opportunities for intervention can occur, and why education is so important. So again, to reiterate some of the terminology, we think of non-alcoholic fatty liver disease as a total descriptive term, and we label non-alcoholic fatty liver, or NAFL, without the D, as the simple form of it. It's simple under the microscope. It's not simple when it comes to patient care or implications for that human. But we think that non-alcoholic fatty liver is when the liver accumulates more than 5% fat. That's by definition non-alcoholic fatty liver, to the exception of a laundry list of things that some of my colleagues will go through in great detail. Namely, alcohol is a main contributor to fat, with the exception of all the other things that may lead to fat deposition in the liver. Anything more than 5% is considered non-alcoholic fatty liver. This category, that is about 25 to 30% of the population, actually is relatively quiet from a liver perspective. Those individuals go on to develop diabetes, heart attacks, strokes, are much more at risk for the cardiometabolic types of consequences, and are much more likely to not, they're unlikely to develop scar tissue in the liver based on what we know. So those of us in the liver world focus our efforts, or try to focus some of our concentrated efforts, on the non-alcoholic steatohepatitis, so the one that's on the right. The inflamed form of liver disease that may or may not include scar tissue or fibrosis. When you see those terms like inflammation, it's invading cells into the liver, which I'll show you on the next slide. Ballooning just means liver cells look like hot air balloons under the microscope instead of their nice organization. And fibrosis, again, just means scar. This is the disease that we expect to progress without intervention, but it also can be halted and reversed with intervention. So under the microscope, this is what the process that we're describing. And again, it's very hepatocentric. This doesn't describe anything that's going on in your blood vessels or your brain or your heart or your kidneys. But at the far left, that's a normal liver, a normal color, kind of like nutmeg. When the liver accumulates fat, it looks just like if you've seen animals, the type of adipose tissue that you see with either chicken fat, et cetera, that's what it looks like in a gross form. And under the microscope, those lipid droplets, those are fat accumulations that are full typically of triglycerides. That accumulation of fat is what correlates with a lot of pre-diabetic type insulin resistance phenomenon that we'll see. The angry form is the third panel. So that's when the fat, the mechanism by which the fat leads to inflammation is one of the million-dollar questions in the field, can lead to scar tissue. And then the very far right is when you have the disrupted architecture, lots of scar tissue, and that's in liver disease world what we think of as irreversible. Everything up until that point, we think with intervention can go backwards, actually. It takes time. So this is a little bit more of a graphic representation of how we think about liver disease and where patients can be rescued and where to intervene with certain types of interventions. So the red obviously is a danger zone. That's what people like me who do transplant, we have safety nets. If you think about the words that are listed there are compensated and decompensated. Decompensated is just a fancy way of saying the liver doesn't work anymore. And when that happens, we have to rescue those individuals with transplant. We obviously want to limit that as much as possible. It's a nice mechanism to have, but certainly not available for the vast majority of the world. So in order to try to help people at different stages of the disease, compensated cirrhosis is an area where the liver has a lot of scar tissue, but still works. So those are individuals that undergo cancer screening, et cetera, and certain types of drugs are being targeted towards scar tissue. The vast majority of people that we want to try to intervene on are those that are much earlier stages of disease, either with simple fatty liver, NASH without significant scar tissue, like stage 1. And those are the ones where we really want to try to tailor good diabetes control, lifestyle management, modest amounts of weight loss, because that can actually hold them away from the cliff. And if we can prevent more people from progressing closer to the edge, the better it is. From a global epidemiologic disease burden, somewhere between 20 and 30% is what we think of the burden of the disease worldwide. So significant numbers. I'll give you some comparisons across countries. Red, significantly more than 30% of the population is thought to be influenced by the disease. As you can see, the United States is in red. Strongly overlaps with obesity and diabetes, but please hear from me that you do not have to have either of those diseases in order to have fatty liver disease. So risk factors are risk factors, but they're not totally inclusive. The PNPLA3 minor allele frequency is the light blue in the pie chart diagrams. So you can see there's a lot of influence from the ancestry component of where individuals come from. And we think that that has something to do with why certain individual groups progress through their diseases faster than others, hinting at the genetic basis or a genetic component to understanding the disease. Now, this is just nuts and bolts basics about risk factors for the disease, and I think there will be some calculators online in case you want to figure out what your BMI is, to figure out if you are in any of these risk groups like obesity. There should be a BMI calculator that's available to you. So type 2 diabetes, obesity, dyslipidemia, so individuals with cholesterol problems, they're all at risk, and then individuals with metabolic syndrome. And a simple, easy, practical way for the general population to think about insulin resistance is circumference. So waist circumference is an easy, measurable thing in terms of how big your pant size is or how many centimeters around. The other things you can figure out based on what your doctors are telling you in terms of your fasting blood sugar or whether or not your cholesterol is elevated. So these are all very practical, Googleable things to help you figure out what risk category you might be in as an individual. The emerging associations are correlated with different types of endocrinologic risk factors like hypogonadism and hypopituitarism. We all know about polycystic ovarian syndrome and its overlap with insulin resistance. So those are pretty well established, not so much emerging associations now. Looking again at the population and the distribution, we focus our efforts on high-risk category groups, but again, I'll reiterate, that does not include everybody. So you can still have fatty liver disease and NASH without these, but we worry a lot about individuals with obesity and diabetes because we worry that their disease will progress faster, namely because of insulin resistance and poor glucose control. You can see the general population estimates at the top, and then the type 2 diabetes in the middle panel between the two groups. And then this slide highlights the overlap between obesity and diabetes in a worldwide population perspective. So you can see that individuals who have a significant amount of weight, that weight excess correlates with increased deposition of fat in the liver. We're developed as humans to try to store fat in subcutaneous pockets. So in adipose stores, the liver is not designed to store fat. So as human weight increases, and again, this varies by body composition and ethnic subgroups, there's more exposure of the liver to fat, and that correlates with increased risk. With diabetes, you can see the same, again, emphasizing the total worldwide population that's under the influence of this epidemic. And to the very far right, you have the comparisons with other very common things that we know about breast cancer and hepatitis C and how prevalent this disease is in comparison to those others. And this correlates with overall mortality in NASH versus NAFLD. So one of the questions that was very early on in the field is, why do we care about this? People will die of cardiovascular disease. Why do we even bother looking at the liver? Individuals with NASH don't always die of cardiovascular disease. Yes, it's true. The highest risk for this disease population is cardiovascular disease mortality. But if you see individuals with NASH as compared to those with a simple fatty liver have more than a 5-fold increased risk of dying of liver-related outcomes. Teasing these things apart, who's accelerated from a liver perspective versus a cardiometabolic perspective, is a goal of many of us. I'm only going to hint at diagnosis because I don't want to take away from my colleagues, but it's to emphasize that the current means of diagnosis is insufficient for dealing with the population. So in order to find out who has NASH and who doesn't in June of 2019, we rely on a biopsy. That's our card-carrying gold standard. Biopsying 30% of the population is impossible, too costly, too risky, etc. We understand this as a community, and we are rapidly trying to develop mechanisms by which we can avoid this. However, it is extremely important to look for those who have NASH and to exclude those who might have a competing risk, a disease that might be treated totally differently. specifically like autoimmune hepatitis, et cetera, et cetera. Our current treatment, and I will leave the majority to my colleagues, includes lifestyle counseling and management. That might not be, that's a good general recommendation for everyone. But if we miss another chronic liver disease, calling it NAFLD or NASH, that would be an error that would lead to sort of progression of liver disease in an unseemly way. One caveat, those of us that have been doing liver disease for some time oftentimes look at biomarkers, and one of the quickest, cheapest, earliest biomarkers are the AST or ALT or SGOT, SGPT, liver enzymes. And so oftentimes patients will come and say, my liver enzymes are normal, my liver's okay. Don't be falsely reassured by this. There are individuals, definitely probably within all of our databases, with all of our healthcare systems, with NASH, biopsy-proven NASH, with very, very normal, hepatologist normal ALTs. So don't be fooled. This is where this disease is not like other chronic liver disease in terms of its necroinflammatory component. One area with this disease that is different than our other two big diseases in adult liver disease, which is alcohol and hepatitis C, is that this disease can start in children. We see fat accumulation in as early as 2 years old. We have more than single case reports with cirrhosis by the age of 8. So the nature of chronic liver disease is downward adjusted in terms of seeing more cirrhosis by a younger age, given that chronic influence that's starting off more earlier in life, as opposed to potential risk factors for alcohol and hepatitis C. That said, there are multiple components that relate, and this is true for children and adults, to the extrahepatic manifestations of fatty liver disease. Again, it's not just related to the liver. It's related to the gut microbiome, intravascular findings, peripheral adipose and how it crosstalks with our muscles and our blood sugar. And then further on, you can see the endocrine pathways, so pancreatic sufficiency and insufficiency, and then significantly cardiovascular disease. So this type of liver disease actually requires you to think much more like an internist from a multisystemic point of view. And then lastly, I just wanted to talk about the transplantation aspect of things, because we currently don't have enough organs to transplant. That's how we are right now in June of 2019. But given some of the projections, if you think about 30% of the population having fatty liver disease and 5 to 6% having NASH, so that's somewhere around 16 million, and then 1 to 2% having cirrhosis, that's between 3 and 6 million just in the United States. That far exceeds our capacity to transplant anytime in the next decade or 2 decades. Granted, 100% of those patients won't be pursuing transplant and won't be decompensating, but the projected numbers you can already see outpace our ability to keep up. One of the trends that we've noticed, in addition to curing hepatitis C, and where our community has learned a lot about the reversibility of liver disease, is that fatty liver disease, and specifically NASH, is actually the #1 indication for transplant now in women, and it is second rising in men. This trend is expected to continue. NASH-related HCC is also a significant indication for liver transplantation, and both of these are expected to rise. So I said I'd be hopeful towards the end, but I do want to give you a couple take-home messages, and that is, yes, this disease is an epidemic proportions. It far outpaces our ability to keep up in terms of technologies, diagnostic technologies, and current therapeutics. Projections are overwhelmingly scary in terms of need and burden of disease requiring transplantation or evaluation in the future. That said, it is modifiable and reversible when caught early. Diagnostic modalities are being developed, as you'll hear very shortly. The most hopeful aspect of things is that a multidisciplinary approach, working together, not just in the healthcare community, but with patient advocacy groups and governmental implications in terms of tailoring lifestyles towards a healthier lifestyle, safer parks, food security, et cetera, is a systemic-wide approach to dealing with this disease. So with that, I think I'm supposed to stay and take 1 or 2 questions. Is that correct? Yes. Okay.
Does anyone in the room have any questions? All right. Do we have any questions online? Because if not, I have a question. So as you were talking, I kept thinking about who do we engage in the public space and who should we be talking to about this? Because it's a lot of information, but it's not necessarily exactly clear who does this messaging go to.
Because of the prevalence of the disease, I think general community groups are a good first target. The amount of information that the average individual can take and hold on to implement individual level change is substantial. That's something I've been humbled by through the years. So community engagement, either whether it's libraries, church groups, et cetera, any group that's motivated towards change, towards healthcare initiatives is one group. And then public advocacy groups that are strategic in partnering with programs, government-wide programs, that sustain healthy lifestyle, especially training children and training families at a very young age, are also strategic interventions that we can do from a preventative standpoint.
Hi. I was wondering what specific advice you give patients or would give your patients in terms of lifestyle modification.
Sure. So our general approach, and I'll tell you, one of my dietitians who's sort of developed all of our nutrition recommendations is here. We spend a significant amount of time when we talk about weight loss focusing on how it actually looks in the person's life. The words weight loss usually don't land very effectively. So doctor time, I'll just tell you my personal approach. Doctor time, provider time is spent on exercise a lot, because unless you take an exercise history and know what that person's level of activity is, it's very hard to integrate into their life. And so I ask about aerobic versus resistance activity. I have a lot of very lean, petite women who are not overtly obese, who have very little muscle mass and insulin resistance and fatty liver. That's a phenomenon I see in New York more than other places. So increasing muscle building, increasing resistance work is tailoring that recommendation towards that individual's lifestyle. If there are limitations in terms of outside places that are safe, you need to know that. So physician time, provider time is usually spent a lot on the exercise aspect of things, minutes per day. Establishing, we generally in the community have a goal of 7 to 10% is our weight loss goal, so it's very modest in order to halt and reverse disease. So giving a weight loss prescription, your goal is 24 pounds by the end of 6 months. This is what it looks like per week. This is how we adjust based on your, and certainly we all know that weight loss is more sophisticated than calories in and calories out. But having a numeric goal is a good approach. And then 45-minute consultations and regular follow-up with either a dietitian or a weekly program. It's behavior change. No one does behavior change well, whether it's CEO coaching or weight loss, unless it's a regular encounter. And so we try to do that quite regularly. So does that answer your question?
Yes.
Okay.
I'm a pediatric gastroenterologist.
Yeah.
And in kids, we don't focus so much on weight loss.
Sure.
And so we focus a lot on
stabilization. Yeah.
Stabilization, but we focus a lot on fructose and
Yep.
excess free sugars in diet. And I was wondering if to what role those things play in a role in your adult clinic.
You know, I adapted only by some exposure to our pediatric advice, making changes family-wide. I think that's good, not just for children, but for adults too. We don't go into specific. High fructose corn syrup is one, but we just try to stay away from processed as much as we can, given the person's income level and what they have access to. But avoidance of high fructose corn syrup is probably one of the few things that we'd say by name, but it's more understanding what the person's intake is at that particular time versus what we need to shift them to.
Any other questions? Or any questions online? All right. Well, thank you so very much.
Thanks, Dr. Hollings.
So next we have our next presentation, Challenges in the Current Diagnosis of NASH and Patient Management. by Dr. Askapour. So Dr. Aman Askapour is an assistant professor in the Department of Medicine, Division of Liver Diseases. He is board certified in internal medicine, gastroenterology, and in transplant hepatology. He is a member of a number of professional organizations, including the American Association for the Study of Liver Disease, the American College of Physicians, the European Association Study of Liver Diseases, and the American Medical Association. He is the author of a multitude of publications, and his research at Mount Sinai will focus on clinical trials and translational research and non-alcoholic fatty liver disease and steatohepatitis. He is the recipient of numerous honors and awards, including the AASLD Foundation Award, the Young Investigators Travel Award, and the Presidential Honors. And so I'm looking very forward to this speech. I have to say, I spent a lot of time reading everyone's articles, so my office is just covered with all of your stuff. So I'm yes, I'm I have a fan club of liver disease specialists in my life. Not everyone has that, but hey, it's how you keep a community healthy. So come on up and.
So thank you all for being here today. I want to thank the organizers for inviting me as well. I'm going to walk around a little bit. I hope you guys don't mind. Let's make this work. So let's move this forward. That's not a good picture of me, but I'm going to talk to you about the challenges in the diagnosis of management of NASH. Okay, here are my disclosures. And so this is just another pictorial to kind of echo what Julia has shown us, the clinical goal in patient diagnosis. We know that the liver starts off nice and healthy, but in fatty liver diseases, there's this progression of that non-alcoholic fatty liver, just the fat deposition, and then furthermore into NASH with varying degrees of fibrosis, and this potential progression of fibrosis all the way up to F4, what we call cirrhosis. And as Julia had mentioned, there is some reversibility. Our mainstay of therapy now is weight loss with diet and exercise. But unfortunately, there's some who continue to progress and go over that cliff like Julia has shown and fall off and end up having cirrhosis with decompensating events. And within this NASH group, Julia had mentioned to you about the steatosis, the ballooning, the inflammation that we see on pathology. I'll show another slide to describe that a little bit more. But these patients are all at increased risk of progression of cirrhosis and also cardiovascular related mortality, so strokes and heart attacks, something we're always worried about in our NASH patients. And identifying those who are at higher risk of progression to poor clinical outcomes, including cirrhosis and cardiovascular events, are our biggest challenges at this point. We need to identify these patients so they don't go underneath our radar. So this is a pictorial. So we use the NAFLD activity score. This was developed by the NASH Clinical Research Network and by Dr. Kleiner, who's a pathologist out of the National Institute of Health. This helps us have the language to describe what we're seeing, and so we can classify patients a little bit better. And as Julia had mentioned, with the steatosis score, it's just greater than 5% fat that we call non-alcoholic fatty liver disease. That gets you a score of 1. 5 to 33, and then it's progressive as there's more fat deposition in the liver. And inflammation is just what the pathologist sees on a high-powered field, how many foci they see. But the ballooning is probably the most important feature, okay? In dead center is a ballooned hepatocyte, okay? This is a perturbed liver cell that's actually evading some apoptotic pathways and also releasing cytokines that perpetuate this disease state. And you can see there are these, the architecture is altered here. There's some scalloped edges. There are these ropey eosinophilic inclusions that we call Mallory-Dank bodies that are actually pieces of cytokeratin. And from this, the pathologist will give us a score. So the NAFLD activity score to understand the degree of disease activity for these patients. So what are the challenges in management and diagnosis of patients? There's some data for some surveys that were out there. They surveyed patients and physicians. This is it's kind of unfortunate about the awareness in the patient community. A lot of our patients feel stigmatized when they hear the word cirrhosis. They say, "Doc, I never drank before. How do I have cirrhosis?" And it unfortunately comes as a major surprise to our patients. Granted, there's a lot more Hep C commercials on TV, so people know about viral hepatitis, but non-alcoholic fatty liver disease is truly under the radar. And that's why I'm thankful for programs like this to bring more awareness. But you can see that 72% of surveyed patients weren't aware that alcohol and viral infection are not the only causes of liver disease, okay? And then 51% still after the diagnosis feel poorly informed about NAFLD and NASH and the consequences of this. They just get labeled and they're like, now what? And then when it comes to the awareness among medical community, a lot of our physicians aren't even aware about this fatty liver. They see it on imaging. They don't know what to do about it. And they feel like they need more information about therapies and management strategies. And 85% are in need of relevant medical information to better understand the disease state and its parameters. Again, it's not just the patients, it's the physicians who need more awareness. And that's what we're hoping to do here today. So what are some of the other challenges? So, this is a complex disease state. This is the liver manifestation of the metabolic syndrome, intimately related to diabetes, obesity, hypertension, hyperlipidemia. And a lot of these patients, again, of surveyed patients, 2/3 were also treated for high blood pressure, and half also had diabetes, okay? But every patient is different. Every patient in front of me is different, and they have differing balances of these other disease states. And when it comes to the public health burden, again, looking at physicians, 85% of physicians are now thinking that this is a public health burden. So, we're all scared about it. We just, a lot of them just don't know how to diagnose it or what to do about it. And 90% believe that their patients are at risk of developing NASH. These are diabetologists, okay? Because we now have guidelines to support that, which I'll go into in just a moment. So this is the laundry list that we as hepatologists have to go through. There's a study that showed the average hepatologist orders $5 million worth of tests a year compared to $3 million of your average gastroenterologist. This is part of it. We need that information. We have to rule out other disease states, and it's like you learned in medical school. You got to take a history. I got to find out if you're drinking alcohol and that's why you have fatty liver. I need to see if you're on medications that are steatogenic that will promote fatty liver disease. We also look at hepatitis A status to see if we need to immunize these patients, B status to see if we need to immunize or if patients were exposed. There's hepatitis C status. So here in New York State, it's law that we have to check for Hep C at least once in our baby boomers. So that's another reason we do it. Then we have to rule out rarer causes of fatty liver disease, rarer causes of liver disease like autoimmune, Wilson's disease, et cetera. We have different modalities here. And I'll tell you, my record is I had one patient who had 4 different liver diseases. And I never would have known unless I did all this. And I told my mentor about it, and he said, well, I had a patient who had 5 liver diseases. So I'll just practice a little longer, and hopefully I can match Todd Stravitz. We'll see. Okay, so the elevated liver enzymes is one bucket. Okay, the next bucket is fatty liver on imaging. And a lot of times this is incidental. I remember being an intern at Kings County Hospital, and it seems like you couldn't leave the ED without getting an ultrasound or a CAT scan. And so a lot of times you get fatty liver, and it's like, well, what do you do about this? And so if you find fatty liver on imaging, you need to ask yourself, does this patient have abnormal liver chemistries? And if so, you should work it up like fatty liver. If they don't have abnormal liver chemistries, as Julie had pointed out, they could still be at risk for fatty liver. So then do they have features of the metabolic syndrome, diabetes, hypertension, dyslipidemia, that would put them at risk? And if they do, then you need to work them up as fatty liver. And if they don't, you need to think about alcohol and those steatogenic medications that I mentioned earlier. So here are the latest American Diabetes Association guidelines that just came out in January. And I'm really happy to know that the endocrinologists are on board and are putting it in their guidelines. So the recommendation is patients with type 2 diabetes or pre-diabetes and elevated liver chemistries, specifically the ALT, or fatty liver on ultrasound should be elevated for the presence of non-alcoholic steatohepatitis and liver fibrosis. And they go on to mention some of the things we've already kind of echoed, that these patients are at risk for liver fibrosis, cirrhosis, and ultimately liver cancer. And there are non-invasive testing that is available that help us understand the degree of scarring in the liver so we can help risk stratify these patients. And I'll go into a little bit more detail later. So these are the AASLD guidelines for type 2 diabetes, which came out early January 2018. So they say patients with type 2 diabetes have increased risk of non-alcoholic fatty liver disease and NASH, and they need to be risk stratified based on their fibrosis, so the degree of scarring in their liver. And they promote 2 non-invasive scoring systems, the NAFLD fibrosis score as well as the FIB-4 score, which I'm going to go into detail what those are. They also mention using vibration-controlled transient elastography or even MR elastography where available to understand the degree of scarring in the liver of our patients. And this just shows the current status of non-invasive methods. So, you know, all these non-invasive tools kind of give us a piece of the puzzle that is our patient. They give us different data points to help us understand what exactly is going on with our patient. Some of them will give us data about the degree of steatosis, the fat. So on ultrasound, on the FibroScan, there's a CAP score, which I'll go into. And there's also MRI PDFF, which will help us understand the degree of steatosis in the liver. There's some NASH serum tests that can help us understand the degree of disease state in these patients. And then there's also several different tests that look at fibrosis, because we know fibrosis directly influences mortality. The more scarring there is in the liver, the more likely you are to die from a liver-related mortality or get a liver transplant. So for the fibrosis, we have several tools, the FibroScan, ultrasound techniques, MRI, and different scoring systems. So let's go into this a little bit further. So NAFLD fibrosis score, developed by Dr. Angulo, is available online. You can just go, Google this, and I just put what a basic patient. We're going to go into a little bit more depth about the positive and negative predictive value, but I like to use real examples. So 62-year-old person, BMI is 33. You give them a check because they have diabetes. ALT or AST is 30. ALT is 60, so a little bit elevated ALT. The platelets are 175. The albumin, so this is the one tricky part. That's why there's a red box there. This is an albumin of 34 in grams per liter. Unfortunately, most of our medical records are in grams per deciliter. So you got to move that decimal point over. So that 3.4 turns into a 34. That gives you a score of 0.827. If you come down here, that actually predicts the presence of significant fibrosis, so F3 or F4 in that patient. This is a patient we commonly see in primary care, in diabetes, and also in hepatology. So then there's also the FIB-4 calculator. So this was developed by Richard Sterling. So when he developed this, he was actually looking at Hep C and HIV co-infected patients. And he was trying to understand who's at risk for advanced fibrosis in that patient population. And then it was later repurposed for fatty liver by Shaw and Sanyal. And so when you use this, the cutoffs are a little bit different. Again, you can go into Google and find this, but the cutoffs are different than what you see online for fatty liver. So I'll caution anybody who uses that to be aware. So I put what I thought was a grossly cirrhotic patient to me. So age 65, platelets of 150 to indicate there's some portal hypertension. AST is 45 and ALT is 30. In our fatty liver patients, when we see this AST go higher than the ALT, that's when we get really worried that this patient may be cirrhotic. And that gives you a score of 3.56. And so I put the different cutoffs here. So greater than 2.67 means the patient is likely has advanced fibrosis, that F3 or F4 disease. So this is somebody we need to be very worried about. Okay, so vibration-controlled transient elastography, what we call the FibroScan, is becoming a lot more common these days, and we're really excited about that because this is a non-invasive tool that we can use in clinic that'll give us a score within minutes, and we actually can share that score with the patient right then and there. So that makes it a more powerful tool instead of, well, I'm going to draw your blood works and I'll call you in a week or two. It's like you get data before you walk out the door. And this gives us two different data points, a liver stiffness measurement in kilopascals, and also a CAP score, a controlled attenuation parameter in decibels per meter, which helps us understand the degree of fat in the liver. There's several different probes. So this is a pictorial to show you. We put this little probe between the rib space, and it just sends a sound wave through the liver. Just kind of feels like a thump. It just taps on that liver and helps us understand what's going on. There's an M probe that looks at a 4-centimeter section. There's an XL probe that goes a little bit deeper for our patients who are a little thicker. And then I hear there's going to be an XXL probe coming out this year for our even thicker patients, so we can get a score on them. And this is just to show you, sorry, the numbers got a little messed up here, that when we have a fibroscan, there's different interpretation that the physician must use depending on the disease state. So we need to understand what disease this patient has to interpret the results. And fatty liver tends to be on the higher side. And a score of 10 or above is when I start to get worried that this patient has advanced fibrosis. MRI, PDFF, and MR elastography. So MRI is a proton density fat fraction. And this is just a pictorial on the top here to show you the varying degrees and percentages. So as that percentage goes up, you can see the liver looks whiter, right? It's a lighter liver, so at 23.3%. When I talked to the radiologist, they told me they've gotten this down from 16 seconds to 4 seconds. So it's actually a pretty quick component of the entire MRI, but MRIs are still, they take quite a bit of time and cost a lot of money. So the MRE portion of this, here's a pictorial at the bottom. So instead of just a probe tapping you in one spot over the liver like a fibroscan, this is a gigantic paddle that goes over the liver and kind of buzzes the whole thing to give us an idea of the degree of scarring throughout that liver. And I'll caution you, the equations are a little bit different. So 3.6 on an MRE actually equates to that 10 on the fibroscan. So scores here of 3.6 or greater get me worried about advanced fibrosis in our patients. Okay, so this was an interesting study out of the San Diego group where they went to a type 2 diabetes clinic and they asked the first 100 patients, none of them known to have liver disease. They said, can we do an MRI PDFF on you? Can we do an MR elastography on you? They got a pretty good show rate. 98 of those 100 patients actually showed up to get their scan, which is pretty good for a study. And looking at patients with greater than 5% liver disease, 65% of those patients had fatty liver without knowing they had a fatty liver, okay? And then when they looked at those liver stiffness measurements of greater than 3.6, so patients with advanced fibrosis, 7 of those 98 patients had advanced fibrosis, and they never knew they had any liver disease. This just talks to the point that fatty liver is a very silent disease state. You need to have clinical suspicion to work this up. So this is just a little bit more depth comparing the different modalities. So looking at steatosis and imaging techniques. So the CAP, like I mentioned to you earlier on the FibroScan, uses ultrasound technology to give you a score. This is actually what the readouts look like on a FibroScan. There aren't any really good pictures. It's just numbers we have to interpret. So the CAP score is over here in blue, and this shows you 204 is actually pretty good. That's normal. There's no fat in that liver. And 350 is pretty high. It only goes from 100 to 400, so 350 is really high. That's a lot of fat in that liver, okay? And there's certain cutoffs we can use. There's some like quality control. So if you have an IQR of less than 30, that shows that that's a pretty reliable test looking at fat in the liver. But you do need to train somebody on how to use this machine, how to know when to step up the probe size for our patients so we can have accurate results. And there's some quality insurance there based on our median divided by IQR that we need to be aware of as physicians and interpreters of these studies. The MRI PDFF, as I mentioned, looks at the MRI visible protons bound to fat divided by all the protons in the liver. So it looks at the fat in the water, and it's actually a really quick test. And it can give us a percentage of fat that they see in the liver. It's highly sensitive. But unfortunately, not everywhere has this technology, and they don't have the software at all sites. But it's something that we're seeing becoming more commonplace, and it's a good thing that we have that. So there's a lot of NASH serum-based tests. None of these are truly ready for prime time yet. This is more in the investigational kind of space that we're looking. But they're looking at a lot of these different features because we know there's lots of different drivers of this disease state. It's not, as one of my mentors, Doug Diedrich, likes to say, it's a dirty disease. It's not like Hep C where it's just a number and a viral load. There's a lot of different drivers of the disease state. People are looking at different apoptotic pathways, looking at the cytokeratin soluble fatty acid synthase as well, different adipokines, adiponectin, leptin, et cetera. And we know oxidative stress is a big driver here, so FGF21, et cetera. Looking at inflammation through TNF alpha, and there's basically a whole laundry list, and we have a different scoring systems that are available. But again, these are all just pieces of that puzzle that are our patient. And I'm excited that we're in a state now where we're learning more about the liver disease. We're learning that it's not all the same. There are different phenotypes, different drivers, and so with different consortiums, we're learning more about this. And Irene will go into that in a little bit more detail shortly. Fibrosis, as I mentioned, is probably the most important feature that we're looking for because we know it directly affects mortality in our patients. And as I mentioned, there's MR elastography, which has that big paddle kind of tapping on your liver to help us understand the heterogeneous nature of this large organ in your abdomen. It's not just one small section that we're looking at. So I think that's one of the powers of MR elastography. But again, it's hard to get MRIs everywhere, and especially with this technology, it's expensive. So it's becoming more readily available, and we're seeing it more in our clinical trials as well. In our vibration control transient elastography, the FibroScan, so it's like you learned in physics, sound travels faster through solid matter. So the stiffer that liver is, so when it turns from this sponge to the brick, as Julia was telling you, the quicker that sound wave moves through it. And we'll give you a higher score to help you understand the degree of fibrosis there. And this is something we do quite often. If you're coming to the liver clinic, odds are you're getting a FibroScan because we have them there, and it's, when you're a hammer, all the world is a nail. Okay. But there are other tests available, some serum-based tests. One of the disadvantages of serum-based tests is you've got to send it out to get the data. But look, it's adding to the landscape and helping us understand different aspects of this disease state. The ELF score is one that's been well described, looking at different features. So looking at ProC3, hyaluronic acid, and TIMP1. And there's different scales there to help you understand the degree of scarring. There's several other tests, fibro tests, active tests, steato tests, NASH tests, looking at different components. And some of them are capturing different aspects of oxidative stress, fibrosis, et cetera, to help characterize this patient population a little bit better. And then back to our clinical scores. So these are the non-invasive scoring system. The whole point of this slide is just to show you that the negative and positive predictive value for both these tests are actually quite good for predicting the disease state. And all this data is readily available to a clinician. They can easily go online, find a calculator, plug these scores in, and help risk stratify our patients. Here's kind of the big risk stratification algorithm that a lot of us kind of do in our head. And I got to thank Dr. Ranella and Dr. Santiago for putting this in words for us. We have a patient with hepatic steatosis on imaging with elevated LFTs. We'll rule out other causes of liver disease. We rule out alcohol consumption. That leaves us with our NAFLD patients. And then we have these patients with a low risk profile. BMIs that are on the lower side, not obese. And here in New York City, we have to be cognizant of the fact that BMI cutoffs are different for different ethnicities. So our Asian population, it's much lower. Above 25 is considered obese. So that's something we need to be very cognizant of. But our patients who are on the younger side, they don't have features of the metabolic syndrome. We've calculated their scores or done a FibroScan, and things are on the lower side. These are patients who kind of just follow. A lot of us will just do FibroScans once a year, see the patient every 6 to 12 months, make sure they're not progressing, and continuing to monitor them because we don't know who the fast progressors are. We don't know if they'll eventually flip over to have NASH in the more aggressive forms. And then you have the kind of folks in between. Sorry, the two got cut off here. So BMI of greater than 29.9, greater than 40, multiple features of the metabolic syndrome, some of those scores in the intermediate range. These are people we get worried about. And these are people we do liver biopsies on to understand the true nature of their liver disease, to understand the extent of their liver disease. And a lot of the times what we'll do is we'll do a standard of care liver biopsy, and then with that biopsy, we'll see if they're eligible for clinical trials as a means to offer something beyond weight loss for the patient. And then we have some folks with scores that are a little bit more concerning. We're worried about them having cirrhosis, advanced fibrosis. Again, these are people we're biopsying, we're doing MR elastographies on to understand the true state of their liver. So here's some challenges in patient management. We have limited guidelines on who to treat. ASOD recommends treatment of patients who have a biopsy-proven NASH and fibrosis. As Julie had mentioned, as of today, we still have to biopsy these patients to know the true extent. I don't have strong non-invasive tools to understand the degree of ballooning in these patients as well. Emery will go into some of the newer technologies out there to look at inflammation. And we're worried about the cardiovascular disease in these patients, right? Because we know that they have other disease states. And there's a lack of treatment options, right? There's nothing FDA approved. I think that's the hardest part about this disease state. It's something we're continuing to work on. Lifestyle interventions are kind of ruling the roost right now. That's what we talk about with our patients. I go over the caloric intake with all my patients. I like to tell them all to take pictures with your cell phone of everything you put in your mouth for a day or two, just to get insight to where your calories are actually coming from, and working on means to reduce those calories, okay? There's a list of other medications out here, but all of them have some issues. Metformin is good for diabetes, but it really didn't have much of an impact on NASH. Pioglitazone is a TZD studied through the PIVENS trial with its own issues. There's weight gain associated with that. GLP-1s look like a promising drug or class of drugs out there that are associated with weight loss, but we still need a lot more data. And vitamin E is a very interesting drug working on oxidative stress. But I'll tell you, the PIVEN study to use a specific racemic mixture of vitamin E used RRR alpha tocopherol. And I've been to the vitamin store looking for that vitamin E, and it's hard to find. I couldn't find it, to be honest with you. And I looked at every single vitamin E they had on the shelf. So it's hard to endorse something at a store that they don't even have what we studied. So these are some of the challenges. But I'm hopeful. We have a lot of clinical trials out there. So I imagine we'll have several drugs in the near future to treat this disease state. Okay. Kind of talked about that for you. I'll just go a little faster because I'm over on time, and I don't want to upset our organizers. But our goal is to identify patients with cirrhosis, advanced fibrosis. These are the people at risk of dying. We want to evaluate them for their cardiovascular disease. And I've taken the role of, I actually start a lot of my patients on statin myself. So I find the primary care doctors aren't doing it, the diabetologists aren't doing it. They're afraid of the elevated AST, ALT. So I do a calculation of the AHA risk factors myself, and I start statins on these patients. And we need to bring more awareness. I think that's probably the most important thing. Bring awareness to our patients, bring awareness to our providers that this is a disease state out there we have to be worried about. And the diagnosis, unfortunately, it's a laundry list of work that we have to do for these patients, often involving a biopsy. And biopsies can scare some folks. It's not what we do on the first date. It's something we do a little bit later as we start to work up these patients. But as of today, we still do them. I don't mind doing them for our patients. And my goal after a liver biopsy is to have the patient to be like, oh, that was it? That was a liver biopsy? Why was I scared? So that's always my goal. And I like to say most of the time I achieve that goal. But there's a lot of non-invasive testing out there, but nothing is really ready for prime time. We're getting there as we learn more about this disease state. And weight loss is kind of all we have at this point. So with that, if anybody has any questions, I'm happy to answer them. I can come back over here.
Can you please tell us who you are?
Hi, my name is Richard Galula, and I'll be on the panel shortly. Dr. Wadachuril said that one of her goals is for patients, NASH patients, to lose 7 to 10% of their weight. I'm wondering, following diagnosis, what you do at Mount Sinai to follow up. What is the protocol? How often do patients come in, and are there other team members as well?
Yes, it's a great question. I think it depends on the individual standing before me. Everything is very individualized for our patients. So it depends, how often I would see them. Depends on the extent of their disease, So if I just have a non-invasive tool like I showed you earlier, if I did a FibroScan, I did the FIB-4 scores, everything's on the lower side. They don't have a lot of those features of metabolic syndrome. This is somebody I probably see every 6 months or so, keep an eye on with blood work and consider doing FibroScans every year or so. Now, our patients with higher scores, that's when I get worried. I tend to follow these patients more frequently, and I usually after the first visit, I'll bring them back in 2 to 4 weeks. We'll do further workup, further investigation, and if I'm worried that they have advanced scarring in the liver, that's when I really think about doing the liver biopsy or even fibrosis level 2 and above. These are patients I want to do liver biopsies on to understand the true nature, because while these non-invasive tools are good, they have an error. They have a margin of error. And so that liver biopsy will kind of give me another piece of that puzzle of the patient to understand their risk of further progression, the risk of liver-related mortality, and potentially the need for liver transplantation. And I also, so beyond just taking the pictures of their food, sometimes we'll send them to dietitians. A lot of the time, they're already linked in with dietitians or nutrition, if they have diabetes, luckily. But we try to take a multidisciplinary approach and always try to involve our diabetologist. I have a clinic that's in the diabetes center, and so I co-manage patients with a diabetologist. That's one thing that we look at. But as Julia does, I just break it down for them. I'm like, I want you to lose 10% of your body weight. Well, that's 20 pounds. Doc, 20 pounds, that's a lot of weight. Well, that's less than 2 pounds a month, right? It's like a pound every couple of weeks, and that seems more tangible for the patient. And then, working on exercise, working on caloric restriction. I focus more on caloric restriction with our patients as a means to lose weight. I had, one patient who lost 100 pounds in a year on his own, just through nutrition, to actually keeping track. He did Weight Watchers. He just kept track of his calories. I've had several patients lose 50 pounds plus. And I tell them, don't drink your calories, because when you drink your calories, it doesn't make you feel full at all. And try to avoid the sugary drinks, the sodas, the juice. Juice, a lot of people think juice is healthy. Man, is it full of sugar. That's one thing we always want them to try to avoid as well.
All right, thank you. Any other questions in the room? All right, well then, thank you so much. And the next presentation is all about the future and how things can change. So Dr. Znani will be talking about what does the future of NASH diagnosis hold. And Amreen Dhanani is an assistant professor of medicine in the Division of Liver Disease at the Icahn School of Medicine at Mount Sinai. She received her hepatology training at the University of Toronto, and during her tenure as a hepatologist at Dartmouth-Hitchcock Medical Center and Mount Sinai, she has developed both a clinical and research niche in fatty liver disease. She is the principal investigator of several industry-sponsored trials in fatty liver disease and has also initiated studies in identifying populations at high risk for fatty liver disease, and has a program underway in screening for that in primary care. She is a member of the AASLD and NAFLD SIG committee and currently serves on both the advisory committee and is a charter member of NASHnet. She also serves on the advisory committees for the American Liver Foundation. She currently collaborates with colleagues across Mount Sinai to provide clinical care for persons with liver disease, including in the departments of primary care, works with diabetologists, emergency medicine, and pulmonology. So the floor is yours. Bring us into the future.
I'm actually going to take that because I'm going to have a stiff neck if I stand back there. Okay, so I have the task to tell you that the future looks bright. Yeah, so we know this is an epidemic, not just in the United States, but worldwide. We don't have great diagnostic tools. The tools that we have currently are liver biopsy to differentiate between the simple steatosis and this non-alcoholic steatohepatitis. We have some pretty good tools that tell us a little bit about, fibrosis stage, and I think our non-invasive tools are pretty good. But really what it comes down to is, how are we going to diagnose this huge population? So we're really talking about 100 million people in the United States. And then when we do get, therapies, pharmaceutical therapies, how are we actually going to follow these patients? And, if you learn from the hepatitis C era, we used to biopsy these patients on a yearly basis when they were on interferon to see how their fibrosis changed. I don't think we can do that for this patient population. So really, over the next 20 minutes or so, we're just kind of go through some of those novel technologies that are coming out, how we can, maybe risk stratify these patient populations, and also how can we follow them. So, like I mentioned, liver biopsy is still the gold standard. We're going to look at some of the diagnostic tools, but most importantly, the FDA recently put out, press release that, really encouraging development of, biomarkers and collaboration with industry, collaboration with, clinicians, on how can we risk stratify these patient populations. So some of the technologies that we're going to discuss are the liver multi-scan, some blood-based serum markers as well, so the NIS4, ProC3, and ProC6. And then we're also going to talk about some big regulatory organizations, which are a group of collaborators such as NIMBLE, the Liver Forum, that are looking at, from a scientific and drug development standpoint, how are we going to actually follow this patient population. And then we're also going to talk about NASHnet, which is a multi-center group or organization that's really going to be creating a registry to be able to track these patients long-term and hopefully understand some of the real epidemiology on this disease. So a liver multi-scan is really kind of looking at three features. So there's features of inflammation, there's features of fibrosis that we worry about, and kind of putting them together, and it really looks at three modalities: T1, T2, and then a corrected portion, which really helps correct for the iron deposition. And so what this study actually looked at was, using a multi-scan in patients who had liver biopsy proven NASH. And they found that, it had great reliability. It was able to be validated when compared to liver biopsies, and did correlate with histological features of both ballooning. So that's that feature of the NAS score that we look at that really helps us define, NAS from NAFL. And it was also shown that when they looked at the liver multi-scan, that you could use it to predict clinical outcomes. Again, the limitations of such technologies, as Aman alluded to, is that it's not available at every center, and it can be costly and expensive. So the NIS4, so this is a blood-based test that's been developed to identify and monitor patients with NASH, so F2 fibrosis and F2 fibrosis or higher. The reason for the NAS score of 4 and higher, so if you remember from what Aman showed you, it really is a NAS score that defines or differentiates someone from having a NASH diagnosis versus a NAFL diagnosis. But also the reason for really focusing in on the F2 fibrosis is that when you look at mortality, both from a liver-caused mortality and an all-cause mortality, it's really at stage 2 fibrosis that you actually see an exponential rise. And so that was really the purpose, to try focus on this, what we describe as a high-risk population, someone who has NASH with, moderate fibrosis. And what it does is it's a score from 0 to 1 that allows and uses several circulating biomarkers. So mRNA, which is 34A, alpha-2 microglobulin, which is actually a component of the fiber test, hemoglobin A1C, and other serum markers as well. And what they did was, in this study, they took the results from the phase 2 study, one of the phase 2 studies, and they actually looked to see how it compared to other serum markers, such as the FIB4, the APRI score, some of the tests that Aman mentioned, and it actually did as well, if not better, with an area under the curve of 0.84. And then what they also looked at, they then broke down the patient population in terms of, those that improved their fibrosis, those that worsened their fibrosis, and those that did not have a change in their fibrosis score. And you can see here that those that improved fibrosis, so this is the graph here, it correlated with their NIS scores. So not only can this serum-based test allow us to identify patients with NASH, with a NAS score greater than 4 and F2 fibrosis, but it can be a potential test that can be used to see how patients are doing. Are they worsening their fibrosis or improving their fibrosis? But also, are they having an improvement, in their NAS score as well? The next serum test that has shown some promise is the PRO-C3 and PRO-C6, and this is really looking at the extracellular matrix, so really some of the fibrogen pathways, so fibrogenesis and fibrolysis pathways, so really when you're really laying down scar tissue, and that's how the fibrosis forms. And so in this study, what they looked at was to see if there was a correlation between the PRO-C3 levels and the PRO-C6 levels with NASH. And they looked at whether there was a correlation between the individual components of NASH, so ballooning, steatosis, and inflammation. And they also looked to see if there was a correlation with changes in fibrosis. So again, what they found in this study as well, that both PRO-C3 and PRO-C6 were correlated with both with the stages of fibrosis. So with worsening fibrosis, you had higher levels of PRO-C3. But then when they broke it down for the individual components of NASH, it correlated well with inflammation and ballooning, but had no correlation with steatosis. So it's probably a good test that can be used to follow someone with NASH versus, simple steatosis. And it also showed a good correlation with changes in fibrosis as well. So these are two potential, serum markers that are probably going to be looked at in the next couple of years as ways to be able to follow this, patient population. So kind of now going into, organizations and programs that we currently have in place that are really looking at, different pathways of different unmet needs in this diagnosis. So one of the things that NASHnet is trying to do is address some of these unmet needs. So we don't know how to recognize this patient population. We don't know where to start screening these patients. And the other big part is we don't know how educating this patient population, and also clinicians who take care of this disease state. So really, the purpose of NASHnet was to create an effective disease awareness, establish an efficient practice model that's scalable and system-wide. So can we then apply it to other healthcare systems, and then also work with the payer system to create protocols to reduce managed care treatment and restrict and how are we going to manage these people with their therapies, with the new therapies coming out. So how are we going to deliver such a healthcare model? So really, the first stage is really identifying the patient. So where will we find these patient populations? So we've talked about, primary care. Primary care is the first place where we see a lot of patients with multiple comorbidities of metabolic syndrome. The endocrinology department is where we will see all our diabetics. So remember, about 50% of these patients who have NAFLD actually have type 2 diabetes. And then, of course, the ones with the more advanced disease will be in hepatology and GI practices. So identifying this is where we see the population. How do we screen this patient population? So based on the tools that Aman's described right now, it's really using the FibroScan and serum-based technologies such as the FIB4. So using things like the FIB4 calculator, NAFLD fibrosis calculator, to first risk stratify this patient population. So if they have a high score or an intermediate score, if it's high, then you then go on to FibroScanning them. And then if they meet the FibroScan cutoffs and they have a high chance of having advanced fibrosis, you then engage them in hepatology care. And then, you continue to follow these patients, prospectively to try gain insight on natural progression of this disease. So really, that's the purpose of what NASHnet is trying to develop. So this kind of just reiterates the multiple players that would factor into such a model. So this is not just the primary care, the hepatologist, and the endocrinologist, but other, departments that would be working together in a multi-system approach to this disease. So cardiovascular disease, getting the dietitians, occupational therapists involved as well. And then another big part of this is patient education tools. So at present, if you go online and try to look for some information from a patient's standpoint, what is fatty liver disease? Anything that's out there, it's bad news, right? No one really publishes anything good. So really, it's always the things that people come back and tell us is, well, I read about cirrhosis and I read about transplantation and that I could die. So really, one of the things is to try to develop good educational tools for this patient population as well. And then really coming up with logarithms and strategies of how are we going to manage these different patient groups of populations. So the person who has a lower risk of having advanced disease, those with more advanced disease, when do we start screening them for liver cancer? When is it appropriate to refer them for transplantation? And just engaging them in all this in the multi-system care. So the way this is designed is that there are 7 sites that are part of the NASH program. The way it's going to happen is it's a collaboration with EchoSense. So EchoSense is the company that makes FibroScan. The plan is to have 2 FibroScans in each of the sites and screen patients with type 2 diabetes or have a BMI of greater than 30, and then kind of engage them in clinical care appropriately. At the same time that this happens, there's a lot of other information that's going to be collected. So there's going to be screening for other comorbidities. There's lots of blood tests that are going to be collected at the same time. There's also going to be a component of biobanking, so we can do hopefully some genetic analysis in the future. So, some of those ethnic groups that have a higher risk of having more advanced disease, but also some of the serum tests that Aman referred to will be calculated, and these will be very useful to actually follow this patient population prospectively. One of the things that the NASHnet system is going to do is going to standardize the FIB-4 score in the EMR system throughout the 7 sites. And so this will be something very similar to like a GFR or a lab test that we typically order. So this is something that would be automatically calculated, and then this is a marker that can then be followed prospectively. So again, allows risk stratification and optimizing referral pathways. So the other thing that we know that the NASHnet has been very successful in doing is they were successful to have a collaboration with Univision. And this morning, actually, one of the NASHnet members did a live interview with Univision, and it was actually done in Spanish. And the reason for the collaboration really was to try target community, especially the Hispanic community, where we know that this is a disease that has a high prevalence. And also probably has a genetic association, which has been shown to be associated with more aggressive disease and liver cancer as well. So partnership through the 7 healthcare systems with Univision, we're hoping to really engage people in the Hispanic community to start becoming more aware of this disease. So jumping on to, to the next 2 programs, so the NIH Biomarker Consortium. So this is a foundation that's actually a group that's part of the NIH, and it really looks at, discovery, developing, and really looking at regulatory approval of biomarkers to support and accelerate the development of drugs. And so the program that we're really going to be talking about is the NIMBLE program. And so this program's actually done a lot of work in other disease states. So Alzheimer's disease, it's done some work in type 2 diabetes. It's actually done some really great work in a lot of oncology subtypes as well, and cardiovascular disease. But really the point of this group is to develop, to work with clinical trials, and when we design clinical trials, like how are we going to actually be able to identify this patient population, and what other substitutes or biomarkers, whether it's image-based technology, serum-based technology, all these different technologies that we're talking about that can be used to follow this disease. So these are just some examples of different programs within the system. So they've had lots of completed projects. So Nimble is a program that actually kind of started almost maybe 1.5 years ago. And really, this is the program that's really focused on NASH and, working with clinical trials and industry in coming up with ways to develop clinical trials, trying to avoid a liver biopsy if possible and how to follow this disease population. So really, the focus is two things: diagnosis and staging, standardize and validate a set of non-invasive markers, so circulating whether, about function of the liver and imaging technologies for the diagnosis and staging, and then looking at disease progression. As I mentioned, this isn't a population that you can probably biopsy all the time, so what serum tools do we have that we can now use to follow this patient population? So you'll see a lot of information coming out over the next couple of years of clinical trials that have already taken place, where now they're applying these different technologies and trying to see what can we learn from whether it's a failed trial or a successful trial. Is there other information that we could have learned besides a liver biopsy that we could have risk stratified patients appropriately? The other focus of this group also is that when we're recruiting people for any type of studies right now, because that's all we really have for people with NASH, is that we have a high screen failure rate. We can't really get as many, people don't meet all the features that, Aman and Julia had described. So really working out, how can we really successfully identify that correct patient, without having to put them through multiple testing. So it's really a collaboration, between the NIH and really three main, investigators or participants, and there's multiple other partners in this program. And it's really understanding information, guidance from the NIH on how to, design clinical trials. The next, so this was actually just released yesterday, and so this was so it's actually official Nimble to launch a project looking at the biomarkers to replace biopsy, and really just stresses the importance of a lot of emphasis that's going to be put through this committee and consortium to really develop these non-invasive biomarkers. So this was just released yesterday. The third group that we want to talk about is the Liver Forum, which Julia's a member of. And really, this is a looking at NASH from a regulatory standpoint. So it's actually a forum or a group of collaborators, not just from a physician standpoint, but looking at patients as well, looking at industry, and looking at academic scientists in the field as well, to come up with ways to identify this patient population again, but also decrease the ambiguity and looking at natural progression. So the Liver Forum's actually done a lot of work with different committees and organizations. So one of the first things that they did was they really worked on how do we define this disease? How do we define NAFLD? How do we define NASH? And so now some of the focuses of this collaboration is really to identify and characterize patient population that need intervention, identify and characterize different phenotypes and how do we monitor progression of disease, collaborate to see where it's meaningful to actually put someone on pharmacological therapy, and actually if you look at this one right here, defining improvement in NASH for treatment trial endpoints, recommendations for the Liver Forum. This is actually a good summary, a really great publication on the tools and the things that this group has learned from the current clinical trials that have already taken place in fatty liver disease. Like, how can they actually use some of the biomarkers that were used to risk stratify and really identify the patient population. So that's an article that I encourage everyone to look at. So again, really the purpose is identification, validation of biomarkers and endpoints, and really getting information from other organizations that are really working in this field. So in conclusion, I feel like I haven't told you that many important things besides saying we're not there yet, we will get there. Main clinical goal is NASH diagnostics. That really is the focus of a lot of organizations. Now, not just from a clinical standpoint, a lot of us who actually take care of patients, but really from a regulatory standpoint, and also from a payer's perspective when, a drug really does get approved, how are we going to follow that patient? Really emphasizing the new diagnostic methods that we have, looking at some of these biomarkers in terms of risk stratification. Diagnostic field is expanding and evolving. The frameworks are being developed to facilitate development of new tools. And with changing NASH diagnosis field, new clinical guidelines will need to be established. And that's it.